Good evening. Welcome, everybody. Thank you for joining us. My name is Chris Rabbit, Vice President and General Manager here at Edge Endo. Really fortunate tonight to have a great program for you all. Happy to see a very good audience in attendance, and appreciate you spending some time with us on this Tuesday evening. Tonight we'll be talking about next generational endodontics with EdgePRO technology, enhancing outcomes, facilitating ease of outcome, and boosting outcome prediction. We're very fortunate this evening to have Dr. Justin Kolnick with us. Dr. Kolnick, as many of you probably know, has been in private practice for over 40 years in the specialty of endodontics. He did his dental school training in Johannesburg, South Africa. After completing some postgraduate study overseas, he then graduated in the postdoctorate endo program from Columbia University before going into private practice in White Plains, Westchester County in New York. His practice is dedicated to fostering excellence in endodontics through education and the incorporation of state-of-the-art technology. He's always been committed to endodontic education, first as an associate clinical professor in endodontics at Columbia University, and then as an attending at Westchester Medical Center and an associate clinical professor in endodontics at New York Medical College. Although he no longer holds these positions, he continues to lecture extensively on a local, national, and international level, and has published several articles on endodontics, and in specific on the topic that we're going to be talking about this evening. Dr. Kolnick has done more for the incorporation of lasers in endodontics than probably any endodontist practicing today, and we're very fortunate this evening for him to be with us and share his experience. And so I'm going to take this time and pass it over to him. Just a housekeeping note, there is an ability to ask questions. On the right side of your screen, there should be a questions tab. You can type in your question. I will collate the questions and we will have those answered at the end of Dr. Kolnick's presentation. So without further ado, I'll pass it over to Dr. Kolnick. Welcome, Dr. Kolnick. Thank you.
Thank you. Thank you for having me, and I'm really excited to share some of my experiences with this this great new technology. The topic this evening is next generational endodontics with EdgePRO technology, and it is mainly a clinical presentation, not going into too much detail on laser physics and research, but the theme of this presentation is related to outcomes. So we're going to talk about how this technology can enhance outcomes. We're going to talk about how it facilitates ease of outcome, and finally, how it boosts outcome prediction. So let's start off by defining a couple of things. For me, the definition of a successful outcome is an asymptomatic functional tooth with three-dimensional healing. So I set pretty high standards, and you know, in order to achieve this type of healing, specifically the regeneration of interradicular bone or focal bone, we certainly need a very high level of cleaning and disinfection. The second definition that I want to start out with is this concept of ease of outcome. This is a concept that I developed, and it's really defined as the ease with which the desired outcome is reached. So not only is it important for us as endodontists to achieve the desired outcome, but the path that we take to achieve this outcome is really significant, because it will determine how much time, how much effort we put into completing the case. So ease of outcome, which path will you choose? Excuse me. I just flew in from Dubai after attending a laser conference there, and 2 weeks ago I was at the European Society of Endodontology meeting in Helsinki, so I'm a little jet lagged. So really, which path are you going to choose? As endodontists, you know, we are all a little bit crazy. Maybe I should just speak for myself, but here when I was in Cambodia and we were visiting this temple that is famous for these trees that are breaking up the temple, I took this picture because what I was thinking was, how on earth am I going to treat these roots? So this shows how crazy my mind is. Anyway, what are the common challenges impacting this ease of outcome? Issues relating to three-dimensional disinfection, specifically refractory disease and recurrent disease. Complex anatomy, we all are pretty much aware of all the issues that we face from an anatomical point of view. A new concept that I like to speak about is the management of inaccessible and unfound anatomy. Dealing with calcified canals, whether it is physiologic or regular, or premature or irregular. Patency issues, how do we manage canals that are blocked, either that have been with retreatments that have been blocked previously or that we ourselves have blocked out. All the issues related to retreatments, altered anatomy, dealing with ledging, blocked canals, carrier systems, managing separated instruments, dealing with perforations, and also dealing with resorption, whether it's internal or external, and what I call simple or complex. So this pretty much sums up all these complications that can impact ease of outcome. Let's look at the advantage of the EdgePRO laser, how it streamlines our workflow and enhances efficacy in everyday practice. By enhancing efficacy and streamlining workflow, it can certainly boost our outcome predicting success of the case. It can facilitate ease of outcome, the ease with which the desired outcome is reached, and also improve outcomes themselves. What are the main applications for EdgePRO? Certainly the primary applications are cleaning, a concept called biofilm preconditioning and disinfection. But equally important, especially as it relates to things like ease of outcome, could be managing patency issues, recapitulation, achieving drainage and decompression of periapical tissues, and managing the myriad of treatment complications that we encounter on a daily basis. But additional applications could involve managing resorption, endoperio situations, sinus tracts, and some soft tissue applications like gingivectomy, but primarily this is not designed as an all tissue laser. So all of these functions, primary, secondary, and additional, can impact outcomes. What do I mean by enhanced efficacy? Well, let's start with the cleaning stage. Dealing with smear layer removal, tissue and debris removal, preconditioning biofilm, breaking up the biofilm, achieving patency in all portals of exit, and at the same time achieving drainage and decompression. So we see enhanced efficacy with all these issues. During shaping itself, we are now recapitulating with laser energy, no longer recapitulating with a small file, and this speeds up the shaping process, specifically in the management of calcified canals. With disinfection, we see an enhanced bactericidal effect. We also see a much deeper densinal penetration, over 1,000 microns into the dental tubules. There's certainly an augmented tissue dissolution during this disinfection process. And we will see also why we're able to reduce the tissue toxicity of sodium hypochlorite. And then we come to managing complications, as I mentioned before, retreatments, unfound or inaccessible anatomy, patency loss, calcification, resorption, perforation, foreign bodies. So this enhanced efficacy is really more of a comprehensive treatment concept with the EdgePRO. And this enhanced efficacy really streamlines the workflow. When we talk about the presentation of treatment, the actual performance of the treatment, and treatment complications. So what I mean by treatment presentation, there's a definite streamlining of the treatment planning process. Because of the utility of this device, we can plan our treatment in such a way to maximize the efficacy with the laser. Predicting outcomes is a favorite topic of mine because based on all the different aspects of laser activation in the root canal system, we are now able to predict outcomes much more confidently. And because of this, we see a much more readily case acceptance from the patients. Remember, patients that come to see us haven't always decided to have the endodontics done. They're still trying to decide between retreatment, for example, or implant placement. So streamlining the treatment performance, we have much reduced treatment time. Our appointment visits now are shorter, and we are also able to successfully manage these cases in single visit. We see also a reduction in treatment complications, both during treatment and immediately post-op, as well as a significant reduction in long-term complications. Let's start out by taking a look at the management of endodontic biofilm. So the stress waves that are generated by activating an irrigant with a laser in a root canal system are powerful enough to disrupt the biofilm, whether it's active or dormant, old or new. And what this does is that it releases bacteria into the planktonic or free-floating state. And this is really significant because it renders them significantly more susceptible to the biocides that we use in the root canal system. So this breaking up of disruption or preconditioning of biofilm is either due to cohesive failure with disruption of layers or adhesive failure, completely removing the biofilm. There's also a direct effect of the stress wave on the membrane of bacteria, increasing the bacterial permeability by creating temporary pores. So this also makes the bacteria more vulnerable to our biocides, whether it's intracanal irrigants or medicaments that we place between appointments. So very briefly, in about 2007, the radial firing tip was released, where the majority of the energy emitted by the laser tip moves radially, contacting the walls of the canal. And the first study that was done really was by Gordon et al. At Temple University. And here they were looking at the original protocol, which was only activation of water and no chemical, followed by activation of the laser in a dry canal. And the very early studies, the first studies with the radial firing tip, we saw a significant disinfection reduction of well above 99% for efficalis at depths of about 200 microns into dentin. At the same time, Shoup et al. Were doing studies in Austria, in Europe, using the same protocol with no chemicals, and they were achieving a reduction, disinfection reduction of 99.85% for efficalis. After that, we started seeing papers where they were activating sodium hypochlorite. This is a paper by Seat showing that laser activation of 4% sodium hypochlorite resulted in undetectable levels of bacteria within dental tubules, while sonic activation and simple needle irrigation failed to eliminate efficalis. Since then, we've had over 100 studies that have come out using different protocols, using different activation of different chemicals within root canal systems. But most recently, so the weakness, of course, of sodium hypochlorite is not only its unpleasant taste. I'm sure you know your patients have tasted the sodium hypochlorite, but the real weakness is the tissue toxicity. extruding any sodium hypochlorite out the terminus of a root canal can certainly have a toxic effect on the tissues. So research at the end of 2019 and 2020 at the University of Barcelona, they looked at activating a diluted form of sodium hypochlorite, 0.5% or Dakin solution. And this forms the basis of my protocol using the laser in endodontics. The first study they did was in simulated canals in glass pipettes, and they activated 0.5% sodium hypochlorite, and they used non-activated full-strength sodium hypochlorite, and both of them were able to eliminate all the bacteria, whereas the non-activated 0.5% failed to be effective against E. faecalis. The second study they did was in extracted teeth, and found that the erbium-wise GG activation was significantly more effective than PUI in enhancing the antimicrobial activity of 0.5% against E. faecalis in extracted teeth. And the final study they did was a confocal electron microscopic study where they showed that YSGG activation of 0.5% sodium hypochlorite significantly increased the antibacterial properties and depth of penetration into the dental tubules. So here we can see in this picture, green represents live bacteria, brown is dead bacteria. Picture C is 0.5% with simple irrigation, and D is 0.5% sodium hypochlorite activated with the laser. And we can see the no evidence of green or live bacteria, so a significant bactericidal effect and also deep penetration into the dental tubules. In all three studies, the laser tip placement was in the canal orifice only and was not preceded by deep placement of the laser tip in the canal with water. So if they would have first preconditioned the biofilm by activating water deep in the canal system, their results may have been even more impressive. The protocol that I've developed over a period of 16 years, I've termed radial apical cleansing. And not to really confuse you, because you know, generally, if you develop a protocol and you give it to an endodontist, the first thing the endodontist is going to do is to modify the protocol. So the protocols that are present in the software on the interface of the units, those protocols are a very good starting point. And once you develop your skill with the use of the laser, you can go into a more advanced protocol. So basically, starting with instrumentation, minimally invasive glide path and canal shaping, preserving tooth structure using hand and rotary instrumentations of choice. When we talk about optimal use, optimal effect of the laser, we do need to shape the root canal. There have been many people posting cases with minimal to no shaping, where the laser seems to have some additive effect. But from an optimal point of view, we need to shape the root canal system to at least a 2004, 2504. And during this shaping, of course, we are irrigating with a side-vented needle with full-strength sodium hypochlorite, or if the canals are really large, some of you may like to use apical negative pressure with the Endovac. So during the instrumentation stage, we are already going to be introducing the laser, and we introduce it with recapitulation. I'll talk more about that later, but basically the laser tip is placed loosely in the canal and activated on withdrawal. This will remove the dent and mud, create and maintain patency and working length. So this is with water only. The first true laser phase is the laser cleaning phase. And in this particular phase, I like to place the laser tip 1 to 3 millimeters from working length, or at the level of obstruction, which is patency loss or severe curvature. We are then activating on withdrawal at a rate of 1 to 2 millimeters per second, repeated 3 times in each canal. What we are working with here is water. This is the settings we use. So whenever I place the laser tip within the root canal system, I'm working with activating water only. What am I achieving during this cleaning phase? Smear layer and debris removal, recapitulation, which I mentioned before, achieving patency, biofilm preconditioning, achieving drainage and decompression, and also the research has shown that the laser activation with water is the most effective way to remove any intracanal medication, such as calcium hydroxide in multi-visit cases. I just put this in here because this is a paper that looked at the impact of needle insertion depth on the removal of debris, just with irrigating with a side-vented needle. And they found that a needle tip position 1 millimeter short of working length resulted in percentage levels of hard tissue debris removal almost 3 times higher than when positioned 5 millimeters from working length. So this is one of the reasons why I like to take the laser tip deep within the root canal when I'm activating water. So to summarize, laser 1 to 3 millimeters from working length, activated on withdrawal from the root canal system. What are we achieving? Smear layer and debris removal, biofilm preconditioning in the main canal and ramifications. We're achieving patency, and at the same time, we're achieving drainage and decompression. This all happens during the cleaning phase. The disinfection phase, we're using much higher energy, but the laser tip is positioned at the orifice of the canal only. You can start at mid-root, but back up to the orifice. And what we do is first we flood the chamber and canals with 17% EDTA. Activate the laser tip for 30 seconds in a static position over each canal orifice. And then we repeat this process using anything from 0.5 to 3% sodium hypochlorite. Very rarely am I using 6% or full strength sodium hypochlorite. What are we achieving? Highly effective bactericidal effect with deep penetration into the dental tubules and ramifications. Lowered periapical tissue toxicity for 2 reasons. 1, we're using a diluted form of sodium hypochlorite. And 2, studies have shown that by positioning the laser tip at the orifice of the canal, while activating a chemical, there's significantly less extrusion of the chemical into the periapical tissues. To summarize, with the disinfection phase, the laser is held for 30 seconds in a static position at the canal orifice. We're achieving deep 3D disinfection in main canal ramifications and deep into the dental tubules. We're seeing less extrusion, and because of that, we're having reduced tissue toxicity because of reduced extrusion and because of using a diluted form of sodium hypochlorite. Some of you may be concerned about the concept of ledging or micro-ledging of the root canal system. This is a picture by Gary Carr, scanning showing activation of a laser without water in the root canal system. So obviously, we're not working dry in root canals anymore, but the reason why this protocol is showing a reduced laser signature of micro-ledging is because once we're done with the cleaning phase with water in the root canal system, when we go to the chemical stage, we do not reinsert the laser tip into the root canal system. So this will reduce the possibility or the incidence of micro-ledging. But lasers and endodontics really is not just about cleaning and disinfection. We've spoken briefly about biofilm preconditioning, cleaning, and disinfection. What I would like to look at now, clinical cases dealing with recapitulation, patency, drainage and decompression, medication removal, and overcoming treatment challenges. Now, of course, many of these applications occur simultaneously. So by recapitulation, you can create patency, and by creating patency, you create drainage and decompression. So they can pretty much occur simultaneously. This is an interesting case that I wanted to bring to your attention. We can see here, upper right first molar, the CBCT picture showing disease on all the roots, radiographic findings, as well as involvement of the maxillary sinus. We see a dilacerated distal buccal root. And anyway, I went ahead with my protocol, treated this case, and 1 year later, we see significant healing. The bioceramics, extruded bioceramic seal is actually now being pushed onto the root surface by the new bone. But the distal buccal root is superimposed on the zygoma. So I couldn't really see what was going on there. So this is the pre-op X-ray on the left and pre-op CBCT scans, slices. And then I brought the patient back after 19 months. And once again, I saw good healing, but the superimposition of the zygoma on the distal buccal root. So I decided to take a scan to evaluate the three-dimensional healing. And what we found was that we had achieved three-dimensional healing on all three planes. But as I'm sure you've noticed, when we're looking at this distal buccal root, I was very successful in perforating the root canal. So what does it mean that by perforating a case like this with significant radiographic finding, traditionally, we would pretty much schedule that patient for apical surgery, not expecting the case to heal. But in this particular case, we can see complete healing in spite of the fact that the canal in the dilacerated part of the root was never entered with a file. Right, my laser tip was placed 1 millimeter short of what I thought was my working length, activated with water, and then disinfected with the laser tip at the orifice of the canal. And I was able to disinfect this inaccessible part of the root canal system and achieve three-dimensional healing. So this is what I'm talking about. Let's take a look at management of calcified teeth. I think pretty much of all the complications that I encounter in my practice, the calcified tooth is the one that is the most common and is the one that can be the most frustrating. In calcified teeth, the laser contributions are locating calcified canals, helping establish glide path, creating and maintaining apical patency, assisting in shaping with recapitulation, and we now scout for anatomy with a laser energy, no longer scouting for anatomy with small files. So even though in this particular case there are no fancy lateral canals or ramifications, if I just go back one slide, you can see that we're dealing with a very calcified upper second molar with some evidence of canal, and we're just pretty much happy to be able to negotiate all four canals in this particular case. So what is laser recapitulation? It is the removal of calcifications and dentin mud during glide path formation as well as canal shaping by recapitulating after each series of files with laser energy and not with a file. So what this does is it greatly assists the shaping of narrow canal systems, managing complexities and reducing our iatrogenic errors. And of course, it does reduce the potential for post-op pain because we are no longer poking out the end of root canals with small files to recapitulate and unblock the canal system. So the laser is used throughout endodontic therapy, not simply to disinfect before canal obturation. Here are some examples of extremely calcified canals. It's an older case, but we can see this distal root here, this is also what I call a laser signature. So the laser signature can be either the lateral canals or ramifications apically, or during anywhere along the length of the canal system, but it could also refer to microledging of a root canal. So here we see good healing after 6 months and 5 years complete healing. What about patency, apical patency? So to me, this is really important, the ability to achieve patency. Patency is, of course, the degree of openness of a tube, such as a blood vessel, catheter, or root canal, but it is also a canal preparation technique where the apical portion of the canal is maintained free of debris by recapitulating with a small file through the apical foramen, right? So we're no longer doing this. When we look at an interesting study that was published in the International Endodontic Journal by Professor Ng, it was quite a comprehensive study, 25, 26 pages long. But when they looked at factors affecting outcomes, they found that achieving technical patency at the canal terminus significantly increased the odds of success twofold, and that the odds of success were reduced by 12% for every 1 millimeter of the canal short of the terminus remaining uninstrumented. Obviously, this is not very scientific terminology, but these were the what they found looking at thousands of cases in a prospective study. But very interesting, they found that of factors related to mechanical preparation of canals, only patency at canal terminus and apical extent of canal instrumentation were found to be significant prognostic or predictive factors for root canal treatment. Remember, initially I spoke about boosting outcome prediction. Well, this is the basis of the confidence in predicting outcomes. But there were many early studies going way back, 56, 1964, 1990, showing that teeth with apically inaccessible canals were associated with significantly lower success rates. And in a more recent study, maintaining apical patency significantly improved the delivery of irrigants into the apical third of prepared root canals. So here we have an example of a tooth. The lower left first molar was referred in for treatment. We also saw radiographic findings on the distal root of the second molar, which was non-vital, and both teeth were treated. And of course, an oldest case here, because this has a longer term follow-up, but we can see we don't shape canals to this extent anymore, and our access cavities are more conservative. But after 5-year follow-up, what we are looking at now is the terminus of these root canals. Laser-activated irrigation can help re-establish patency without ever having to achieve patency with a file. So when you think about this, this can really change the way you manage your cases. It can really streamline the treatment of cases where you are not able to achieve patency with a file. So once again, this appearance at the terminus of the canal where patency was not achieved with a file, this is what we call the laser signature in the apical region. Laser patency is creating and maintaining foraminal canal patency and cleaning by activation of intracanal irrigant with laser energy. This can be achieved without ever having to pass an endodontic file through the foramen, but it does require placement of the laser tip at the level of patency loss. So here we can see searching for an MB2, could not find the MB2, laser placed at this level, activated only with water, and we can see the re-establishment of patency on that MB2. So what does this do? This effectively reduces our concern, the operator's concern, over complicated canal anatomy. We no longer are obsessed with this complicated anatomy because The laser does the work. The laser does the walk. The laser does the talk, and it manages this complex anatomy for us. So what is the protocol for achieving laser patency? The laser tip is placed at the level of blockage or obstruction, activated in place for 2-3 seconds, and then withdrawn at a rate of 2 millimeters per second with water, activating water only from the handpiece. We then flood the chamber with 17% EDTA. Now the laser tip is placed at the canal orifice and activated for 30 seconds in the static position. Right, the air and water are turned off, and of course we're now activating the EDTA. And once that is completed, we can see that apical patency is now achieved. And then of course we follow it up with the disinfection, with the flooding the system with a diluted form of sodium hypochlorite. An older study, 8-year follow-up, of course, a very large access cavity, certainly aggressive instrumentation, but it is an older case. It's probably 10 or 15 years old. So as you learn to use the laser, you will be able to manipulate the settings if you want to increase the power. In a case like this, we would want to do that to overcome the blocked canal or the loss of patency. So part of the training, you will learn how to do that. Let's take a look at this case. Upper left first molar. There was no patency in any of the 3 canals. In each of the canals, the hand file was up against the brick wall. Even trying to put a little curvature on it and to do that endo dance, could not get away open into any foraminal canal. We can see that all 3 roots have got radiographic findings, so we now become a little bit more obsessive about achieving patency. So here laser patency was established in all 3 roots with laser activated irrigation, first with water and then followed with a chemical. The system was sealed with BC sealer and single cone technique. So let's take another look at this case. So what happens in this case, the working length now is an estimated measurement, usually taken off the CBCT. Let's say the measurement of the CBCT is 21 millimeters, and in that particular root, our file is at 19 millimeters. So we know that we are in the proximity of the canal terminus, and that's all we need to have, because the laser takes over at this point, irrigating the water and achieving patency. Scouting apical anatomy with a file becomes redundant. Don't spend any time scouting the terminus of the canal. Remember, we're probably dealing with multiple foraminal canals, deltas, ramifications, isthmuses, right? There's no way we're going to get hand files or rotary files into all these ramifications. So scouting apical anatomy with a file becomes redundant. You can now begin to see how this streamlines the process. This will have a significant impact on how we predict our cases, how we plan the treatment, and how we perform the endodontic therapy. Achieving laser drainage and decompression is really important. Often we will instrument a case that has swelling and we fully expect drainage to occur, but no drainage happens. After activating the laser tip deep in the canal with water, in most cases we see a very, very active drainage of pus or buildup of fluid at in the periapical tissues. So this may be during primary treatment, whether it's single visit or the first visit where we get drainage, or when we come in on our second visit, sometimes there's a little drainage after we activate the laser. This could be residual pus that was never removed the first time, or pus that accumulated between the first and second visits if we had prescribed antibiotics. So in this particular case, patient was referred in for the lower second molar, we can see that all 3 molars are sick puppies, right? But in this particular case, it was a 2-visit treatment. When I went in to do my final cleaning on the 2nd visit with the laser in the mesial root, I got some pus to drain. But after 3 or 4 paper points, I was able to stop all drainage. And then I just went ahead and obturated the case. There is no reason to spend another visit disinfecting the case. So what about other treatment challenges? Anatomical, retreatments, perforations, separated instruments, resorption, removal of medication. Well, anatomical, of course, anatomical is a real problem. It has been a real problem for all of us. Often we can find a single foraminal canal when in fact we're probably dealing with 2 or 3 foraminal canals. Managing curved canals with this protocol is definitely not a problem. We do have to modify placement of the laser tip during the cleaning phase with water. So here we can see a moderate curvature with 2 canals merging. A more severe curvature of the mesiobuccal root with a separate MB1, MB2 portals of exit. Here we have an S shape. This one is more of a severe curvature on that mesiobuccal root. And then finally, a dilaceration. All of these cases were managed with laser-activated irrigation, my protocol, and then all of them were obturated with bioceramic sealer and single cone gutta percha. This is an interesting case because assorted curvatures and ramifications, of course, can occur in the same tooth. So here we are looking at the upper left first molar. We can see a dilacerated distal buccal root, some curvature in the mesiobuccal, maybe some ramifications in the palatal. And here we can see that we do not need to place the laser tip beyond the curvature of the dilaceration. Placing it at this point, activating with water, is extremely effective. So here we can see in the post-op the dilacerated distal buccal root, MB1, MB2 with separate portals of exit with no transportation of these portals, and then the ramifications and lateral canal in that palatal root, all managed with laser activated irrigation. Lateral canals, well, most often we see lateral canals when we obturate the cases. Maybe we don't know they're there, and we're pretty happy with ourselves because we fill the lateral canal, and then we go to great pains to explain to the patient, and the patient doesn't really understand what it is that you're showing them. I once showed a patient radiograph of lower incisors, and she said to me, they look like my toes. So, you know, I really don't waste time showing post-op images to patients after I'm finished, because I'm not ready to go into a whole discussion. Some patients can really go off on a tangent. All they want to know, doc, are you happy with the result? Yes, I'm extremely happy with the result. I expect a really good prognosis for this tooth. But getting back to lateral canals, when we see a lateral canal on a lateral lesion on a root, we expect or hope that there's a lateral canal emerging at the midpoint of this radiographic finding. So after doing our protocol, we can actually spend a little bit more time activating the laser at the level where we anticipate the lateral canal to be branching off the main canal. Okay, so we will activate once again with water. Anytime the laser tip is deep in the canal, it is with water only. And we can get obturation and management of the lateral canal. But with CBCT, often we're able to see the lateral canal, and then we can actually measure much more accurately and activate the laser at that level and manage the case. So active management of a lateral canal is different from finding a lateral canal after obturating a case. So we can actually use the laser to manage where we expect the lateral canal to be. So here we see different things going on here. We can see a lateral lesion, a lateral apical lesion. Looks like the canal emerges this way, apical lesion here. So this is a healing case showing the lateral canals. Here we see immersion here and patency achieved with the laser in that mesial root. Isthmuses, by the time I'm done with this presentation, I think you're going to look at isthmuses a little differently, especially if you are a laser user. But isthmuses can be very valuable for us to manage inaccessible and unfound anatomy. When we suspect the presence of an isthmus, any root that has two canals within that single root, we expect there to be isthmus or communication between the two canals. Mesial root of a lower molar, MB1, MB2, lower incisors with two canals. So basically, we would reinsert the laser tip at the level of the suspected isthmuses. In this particular case, you can see multiple isthmuses and a delta terminus to the canal. Often with CBCT, we can identify exactly where the isthmuses are and place the laser at that level, activating water, of course, to manage the isthmus and possibly anatomy that it communicates with. C-shaped canals, very easy to manage. Okay, here we see a typical C-shaped canal. The laser tip is just placed along the C-shape. 3 or 4 different applications, once again with water and then followed with disinfection to very rapidly manage the C-shape. Retreatments, of course, we find all types of things with retreatments, ledges, blockages, loss of patency, missed canals. So the laser definitely facilitates retreatment. Here we see a case that is poorly treated, distal abutment of a bridge, but looking at the axial view, we can see the mesial canals and the distal lingual canal is extremely, all 3 of them, extremely calcified. So once again, you're being asked to predict an outcome for this case. You're not sure about these calcified canals, unless, of course, you have a protocol that allows you to manage these calcified canals and to manage retreatments. The use of the laser is extremely effective in managing the bioburden in these systems. It will not actively remove or soften gutta percha, but any tags of gutta percha, those annoying tags that we see on the walls of the canal, can easily be removed by activating an irrigant in the root canal system. So here's a more complex case. Lower right molar, distal abutment of a bridge, silver point, old apical surgery, lesion on the distal root, and about half the length of the root was removed by the oral surgeon during the surgery, amalgam retrofillings. So here we want to retreat the case. We can see the beam hardening of the silver points, quite annoying. But on retreating the case, we can see that the amalgam retrofillings were actually holding up well. No real sign of breakdown around the retrofilling, but the lateral canal in that distal root was significant. And here we can see healing after 4 months. I thought quite an interesting case. Once again, to predict an outcome on a case like this, very difficult to be confident in predicting an outcome without the use of the laser. Managing perforations. The value of the laser is that it can clean and disinfect the perforation before obturation. So here we can see a perforation of the anterior abutment with a post. Post is removed. Removed tooth is retreated, but the laser tip is inserted at the level of the perforation, activated with water, and then afterwards with the laser tip at the orifice of the canal with a chemical. So you'll see a post-op and a 5-year follow-up. Still a little bit of occlusal forces on the bridge because of the thickened PDL. Interesting case, this patient presented in my office. Root canal therapy was completed by an endodontist down the road, and the patient had persistent pain in the tooth. Of course, the crown is not satisfactory. There are issues with the crown itself, but the patient was visiting from Japan, and I said, look, I have to look internally. The CBCT didn't show anything definitive, and when I looked internally, we could see a large perforation with mushrooming tissue up into the tooth, right at the position where the distal buccal root would normally be, the distal buccal canal, but this tooth was a two-rooted molar, right? A perforation. The first issue of event, the first issue that we need to deal with here is to ablate the tissue that's growing up into the tooth. And we do this with the laser so that the tissue is now above the level of the perforation, allowing us to seal it with MTA. So we can use either the number 2 tip or the number 3 tip, okay, using the gingivectomy setting of 100 millijoules per pulse, and we are able to use, even though these are radial firing tips, we are able to use the EdgePRO tips, the number 2 and the number 3, to ablate tissue, and this allows us to finish the case and a 5-year follow-up, and we can see she still has the lousy crown on the tooth. Dealing with separated instruments, specifically instruments that we cannot remove, our purpose would be to bypass the instrument. Now, most of us will try with a small file to bypass the instrument, and in many cases, when we think we're bypassing, we are either perforating or creating our own canal, not really able to bypass the separated instrument. So the 2 teeth that I have most difficulty with in terms of managing separated instruments are the second molars, the upper second molar and the lower second molar. In this particular case, we're looking at an upper second molar with a separated instrument at the terminus of the canal. Maybe an attempt was made by the previous dentist to remove it, I'm not sure, but there's no way that I'm going to remove excessive tooth structure in an attempt to remove this. If my laser activation of water at that level is not able to dislodge it, the next step that I'm going to do is I'm going to bypass it. How significant is it? Well, we can see significant disease associated with the separated or retained instrument. So the case was treated with the radial, with my radial cleaning protocol, and we can see a 16-month follow-up. The tip was never removed, and when we look more closely, we have 3-dimensional healing. There was significant disease initially, and when we look more closely at that mesiobuccal root, the tip is still present, was never removed, and yet we were able to achieve 3-dimensional healing. Well, I said upper and lower second molars, so here's a lower second molar that was referred in to us. We can see a separated instrument protruding out the end of the root, significant radiographic finding or disease associated with it. The idea is now to use laser energy to bypass and then to disinfect around that separated instrument. So the immediate post-op case, we can see extruded sealer. Not sure if it's extruded from around the separated instrument, but the canals did merge, or whether it's from another portal of exit. But as you say, the proof is in the pudding. 5-month follow-up, we can see now the healing that we achieved after 5 months with the separated instruments still in place. This can also apply to retreating cases with amalgam retrofillings that are leaking. We don't have to remove it. We don't have to resurgerize it. We can use laser energy to clean around the leaking amalgam retrofilling and to disinfect. Resorption. Well, in specifically invasive cervical resorption, I think that people are retaining their teeth longer. We're seeing cracked teeth. We're seeing a lot of orthodontic treatment in young and older patients, and a surge in the number of invasive cervical resorption cases. So we use the laser at the level of the defect internally. Of course, this is an external resorption managed internally. And we can see what happens after 5 years, even though the tooth was never properly restored. Or when we look at this under the microscope, we can see this honeycomb effect where dentin is preserved. We're no longer repeatedly using TCA and a round burr until we nearly perforate. The idea is to use some TCA initially, a round burr or ultrasonics initially to open up, and then to let the laser do the work. We can ablate the tissue either by direct laser ablation, by working dry, because the erbium energy seeks out water. Water is the chromophore, the entity that absorbs this particular wavelength, and the water in the invading tissue is then ablated. We can also activate full-strength sodium hypochlorite to dissolve the tissue. And generally, I use both laser applications, and we have specific settings for whether we're working dry or whether we're working wet. And generally, we'll use the number 2 tip, the greater diameter tip, right? So working dry, of course, we turn the air and water off. Working wet, we are going to work generally with full-strength sodium hypochlorite. So we know from the study and other studies where they looked at pulp tissue dissolution ability of sodium hypochlorite by various activation techniques. One, sodium hypochlorite, no activation as the control, manual agitation with warm sodium hypochlorite, ultrasonic activated sodium hypochlorite, photodynamically stimulated, and YSGG erbium laser activation. And what they found was that the laser activation with the YSGG, which is the wavelength of the EdgePRO, was statistically the most effective in dissolving pulp tissue, followed by ultrasonic. 85% residual weight loss with the laser activation, and only 35% residual weight loss with ultrasonics. So this is why we use the activation of full-strength sodium hypochlorite to dissolve the invading tissue. Now, I'm not sure how many of you would treat this Heather Say class 4 case. When I lectured recently at the ESE meeting in Europe, and there were 600 endodontists in the audience during my lecture, and one person said that they would manage to treat a case like this. I found out afterwards that he was a laser user. But using this protocol, we can use the laser to ablate the invading tissue, and here we can see a 7-year follow-up. This was a patient that was too young for an implant. The maxilla hadn't finished growing. The idea was to remove the tooth at a later age and place an implant. And it is now 12 years that has passed and the tooth is still in place. Another example of how we manage external invasive resorption via an internal approach. This is a recent case, and I will show a follow-up as soon as I have it. So, very exciting, the management of invasive cervical resorption, significantly more effective than other laser protocols for example, the pips or sweeps technique, because there the laser energy is not brought deep into the root canal. It is kept in the chamber. Some internal resorption can be quite complex, as you see here in this distal root of a lower molar. So the case was retreated, laser used to clean the internal resorption. And here we can see a 3-year follow-up showing the pattern after obturation with bioceramic sealer and gutta-percha. What about inaccessible and unfound root canal anatomy? Well, this is a big issue for us because we have scans that show all this crazy anatomy. We have clear teeth like this from my friend Francisco Balandrano in Mexico, who developed a clearing technique to show internal anatomy. Well, this unfound and inaccessible anatomy can really have a devastating effect. It can alter treatment plans. It can impact our ability to predict outcomes. It can influence the outcome itself, prolong symptoms, extend treatment time, searching for this unfound anatomy. This in turn can promote iatrogenic complications like perforations. This will further compromise the structural integrity of the tooth by searching for this unfound anatomy and leading also to treatment failure. So there are all different types of situations where we encounter inaccessible or unfound anatomy, whether it's anatomical anomalies, even dens in dente, ramifications, multiple foraminal canals, merging canals, dividing canals, calcified canals, not allowing us to reach the entire root canal system, blocked canals, either from retreatment or from anatomy, iatrogenic issues, ledging, perforations, transportations, or creating situations with inaccessible anatomy, resorption, as I mentioned, and foreign bodies. A separated instrument can certainly block a canal, making the anatomy inaccessible. But the concept of retrodontics can mitigate this problem. Retrodontics is a term that I coined, and by definition, it is the non-surgical management of inaccessible and unfound root canal anatomy via a communication with another canal. Via a communication with another canal. Let's look at some clinical cases. Here we have a situation of a lower incisor where I was unable to find the lingual canal. We know that the canals merge at this level in the root canal system, and I had to make a decision whether I was going to remove more tooth structure, searching for that unfound lingual canal, or whether I was going to try retrodontics to manage the unfound lingual canal via a communication with the found labial canal. And we do that by activating the laser at the point where they merge, and then try to retro-treat the unfound root canal. And in this particular case, you can see how the unfound, uninstrumented root canal was managed via the communication with the found labial canal. Single cone gutta-percha bioceramic sealer. Here we have another case looking at the bicuspid. Here I had trouble locating the buccal canal. It was extremely calcified. Once again, we see that the canals merge at this level, and I was not going to remove any more tooth structure trying to find that buccal canal. Plan was to activate the laser with water at that level, followed by disinfection to manage the unfound buccal canal. This is the post-op, and you can see how the buccal canal was managed via retrodontics and also successful management of the complex terminal anatomy of this root canal system. So here we have what I call an elusive MB2. We can see that the MB2 merges and seems to separate again, but the main lesion appears to be lateral on the root, and we are hoping to find anatomy that emerges towards this defect. So in this particular case, the idea was to apply additional laser energy, activating with water at that level in the hope of finding this additional inaccessible anatomy. So here we see an immediate post-op, right? And more importantly, a one-year follow-up showing significant good healing. So here we actively went after this anatomy. It wasn't an afterthought. It wasn't something that we found after obturation by surprise. This was another difficult case where we had problems locating the calcified palatal canal. Seems to be disease associated with the palatal aspect of the tooth, but we are anticipating some type of an isthmus at this level, and we're hoping to manage this part of the canal via that isthmus. So although it's not that clear, we can see I made a valiant effort trying to find that unfound palatal canal, right? But we can see sealer emerging here. And we can see sealer emerging here post-op, and this is 1 year later. So managing unfound and inaccessible anatomy with retrodontics. This I thought was quite an interesting case. This is a 3-year follow-up on a case where we had significant disease, and we can see the disease associated with the mesiobuccal, MB1, MB2. MB2 was never found. Significant disease on all roots, involvement of the sinus. And this is a 3-year follow-up showing 3-dimensional healing. But on a closer look at this 3-year follow-up, we see something strange going on at the terminus. And when we took the scan, this is just to remind you with the disease associated with the mesiobuccal root, involving the sinus, eroding the floor of the sinus. So here we see the 3-year scan, and we can see how by activating the laser at that level, we were able to manage the unfound, the terminus of the unfound MB2, allowing us to achieve healing. This allows us to rethink the management of inaccessible anatomy. This will change the way we plan our case. It will change the way we predict the outcome. Rethinking canals that merge, canals that divide, and the role of isthmuses. Remember, isthmuses can be our friend. Looking at all these complications that I mentioned initially, we're pretty much able to manage these with laser-activated irrigation with the EdgePRO. So this comes to predicting outcomes. Now, some of you may have this this magic bowl in your office, a glass bowl to predict outcomes, but I don't. This is an interesting case. This is a female patient. She had root canal therapy on the first and second molars. First molar treatment failed. It was retreated. The retreatment failed. She had the implant placed and was in love with the implant. She loved her implant. So when the treatment failed on the second molar, she wanted to go straight to extraction and implant placement. And the dentist said to her, well, no, I'm using a different endodontist now. He uses a laser protocol. I'd like you to go to see him for a consultation. So she came to see me, but she was angry. This is this angry patient that comes in, that throws her forms down at the front desk, that's rude to your staff, that really is just an unhappy camper. So I walk into the room, and without even saying hello to me, she says, "What is my prediction? What is my prognosis for retreating this case?" Well, I'm thinking to myself, well, let's do our due diligence. We take our scan and we see that this tooth is a sick puppy. Radiographic findings on all three roots, an unfound MB2, calcified, and I'm thinking to myself, do I want to treat this patient? She's really a problematic patient. If I say to her, well, the success is 10%, she's gone. I know I'll never see her again. But I don't have a crystal ball. But what I do have is a protocol that enables patency at the canal termini, supports deep 3D disinfection. Remember the Ing article about predictive factors for outcomes. I have a protocol that manages inaccessible and unfound anatomy, retrodontics. And I have a protocol that helps overcome most complications that we encounter. So I looked at her, and against better judgment, I said to her, 95%. She said to me, what? No one has ever said that to me. 95% retreating this tooth, an upper second molar? I can't believe it. We retreat the case, a 1-year follow-up, 3-dimensional healing, the ability to predict outcomes with confidence. So we can rethink expectations with laser-assisted endodontics, ease of outcome, achieving results like these. Well, I must tell you, I was just as surprised as this baby when this thing healed like this, but I thought I'd show it to you anyway. Remember what Vince Lombardi said. He said, perfection is not attainable, but if we chase perfection, we can catch excellence. Here we see an upper first molar, significant disease, retreatment, 1-year follow-up, 3-dimensional healing. Upper second molar, 3-dimensional healing. Another upper molars, loss of interradicular bone, 3-dimensional healing. So guys, the EdgePRO, this laser is really your future. All these advantages, easy to use, low cost, no need to build up these teeth, reduce treatment time, all these things. But most importantly, there's no clinical contraindication to the use of the laser, whether you're communicating with the sinus or with the inferior dental canal. No clinical contraindications, and of course, low cost per case. The cost of one tip, I'm not sure, approximately $20 or $25, $20. The EdgePRO laser contributions, removal of smear layer tissue and debris, maintenance of patency without having to pass a file through the foramen, elimination of apical vapor lock, which I never mentioned, disruption of biofilm, deep 3D disinfection, effective management of endodontic complications, reduction of chemical irrigant usage in terms of concentrations, successful management of refractory disease, increasing your level of competence and confidence while reducing stress. As I said initially, streamlining workflow by reducing treatment time and promoting single visit treatment. The return on investment is not only financial, it is also emotional by reducing stress. Our days become much easier to manage, the cases become much easier to manage, and the patients become much easier to manage. Enhancing outcomes, facilitating ease of outcome, and boosting outcome prediction. Thanks, guys. We're done. 45 minutes. Okay. So
Thank you
we'd
very
like to
much,
open
Dr.
up.
Kolnick. Yes, I remind our audience, I know it's getting a little bit late, but if you do have a question, please type it in. I have a couple that we'll go over in the interest of time. Then we'll cut it off at just a few, and we can touch base with Dr. Kolnick if there are any other pressing questions. One thing I know about Dr. Kolnick, he's very accessible, and as you can see, his passion for really this discipline and really what it's done in the field of endodontics is second to none. So we appreciate everything you've done to really move this forward, and I know many out there that have followed what you've done and your presentations in the past appreciate it as well. So a couple questions. Can you describe your obturation technique? Are you utilizing a pumping technique of your GP gutta-percha cone to extrude sealer into the anatomy since you're using a single cone technique? Thank you.
Okay, so I don't pump. I will coat the gutta-percha cone with sealer after, of course, putting sealer in the canal, and it is a single movement for me to place the laser tip from entry to terminus. So no, I do not pump. I really don't use much the use of things like a lentulo spiral, very rarely. So I think that I really rely on the laser to open the canal system for me.
Thank you. How do you manage negotiating the fiber tip to within 1 to 3 millimeters in very curved anatomy?
Okay, well, as I mentioned earlier, I showed a variety of cases with curved canals, and the ideal position for me is to be 1 to 3 millimeters, but that's not the only position where the laser tip is effective. So even if you're 5 millimeters from working length or at the level of greatest curvature, I showed one dilacerated case where the dilaceration was in the coronal third of the tooth. The velocity that you impart to the water and to the irrigant can be as much as 20 meters per second. So we are definitely getting that irrigant, whether it's first water and then the chemical, we're definitely getting it to all portals of exit. There's no need to take it all the way to the terminus, but if you are dealing with a blocked canal or a separated instrument, then it is ideal to get that laser tip to the level of the blockage and activating with water at that level. Now, we can also play with different settings. We can vary the energy per pulse in cases where we may not be able to get the laser tip more than halfway down the canal. We can actually work with greater energy, which imparts greater velocity to the irrigant. So this is all part of your training and your experience using this technology in all different types of anatomy within root canal systems. But you can see that my activation of the chemical is with the laser tip at the orifice only. And we can see from the Betancourt studies that were done in Barcelona, specifically that the third study they did, showing the killed and the live and dead bacteria, their activation was only at the orifice of the canal.
Can the laser remove pulp stones?
They can certainly help remove pulp stones, especially those type of stones that you can see there's a little bit of movement, the type of stones that an ultrasonic tip may just, flick out of the canal or pop it out. But what we find is that there are those really small, microscopic pulp stones, tiny pulp stones, that the laser is most effective in removing from the floor, from around the orifice, the entry to the canal. Nothing worse than a small pulp stone dropping into a canal after you've instrumented it. It can be brutal to try and get that out. The laser can help you, but yeah, it can be very effective in removing pulp stones. Those pulp stones that are really firmly attached to the tooth, that won't budge with ultrasonics, you won't remove those with a laser.
Thank you. One last question. I've heard the laser is easy to use, the EdgePRO. Can you comment on the learning curve?
Well, I think that with proper training and understanding of how lasers work, the learning curve can be really fast. You know, I would think that, you know, you'll be a little tentative the first week if you will be using it on every case. You'll probably start with lower power, the settings that are pre-programmed in the unit. And the learning curve should not be that great for an endodontist. For a general dentist, it's greater, because the general dentist is also dealing with a lack of knowledge of endodontics. But once you understand how the laser works and how you need to do some shaping and preparation in the canal, then I don't think that the learning curve is a problem.
Well, in the interest of time, I think we'll stop there. Dr. Kolnick, I know it's getting late. Do appreciate your time. I know you need to get some rest, having just returned from the UAE. But once again, another very insightful and very educational presentation.
It's 3 in the morning for me.
Yes, I know. It's getting late. And we thank the audience.
Thank you.
What's that?
It's my pleasure. And if anyone needs to contact me, please drop me a line.
Yeah, we will make sure that people know how to get in touch with you, and we appreciate you always being as accessible as you are. We thank everybody for joining this evening. Thank you for staying with us rather late this evening. On behalf of Edge Endo, thank you for your support, and we look forward to working with you. Have a great rest of the week, and we'll be in touch soon. Bye-bye. Good night.
Good night, everyone. Bye. Bye.